First of all, I want to thank Professor Methylthioadenosine and Professor Park and organizing committee for the invitation to participate in this web meeting. It's a great pleasure and honor to present at the prestigious seminar in Turkey. Unfortunately, I'm not with you in the same room, and I will give you the live presentation. I wish all of you are safe and healthy. This is outline of today's talk. I went to Turkey in 2011 to participate in the Turkish-Japanese Scandinavian Mesothelioma workshops. Dr. Baris was alive at the time, and he gave us a lecture on mesothelioma in Turkey. We visited villages in Cappadocia where the residents were exposed to thelioma. In 2014, we had an international symposium on malignant mesothelioma in Japan. Dr. Onnau from Turkey and Dr. Järpe from Karolinska Institute in Sweden and Dr. Michael from USA came to Japan to participate in this symposium. This slide shows amount of asbestos imported in Japan and death toll from mesothelioma in Japan. The death toll from mesothelioma increased 40 years, approximately 40 years later, the increase of amount of asbestos imported. This slide shows the predicted peak year of mesothelioma by Dr. Robinson in Australia. The predicted peak year in Japan of mesothelioma is 2025, which is 4 years later from now. This graph shows death toll from mesothelioma in Japan in a year. The number of deaths from mesothelioma in 1995 was only 500. 10 years later, this number has become twice, and in 20 years later, the number has become 1,500. And the number has decreased a little in these few years. However, it is not clear whether mesothelioma decreased further or increase again, because there are several ways before. I want to show two cases. This slide shows why I'm interested in pathology of mesothelioma and started to study how to differentiate mesothelioma from reactive conditions. On the left-hand slide, case 1 shows slight pleural thickening. And case 2 also shows slight pleural thickening. Both patients came to our hospital in 2002. So this is about 20 years ago. Both had been exposed to asbestos. But biopsy was performed and pathological diagnosis was sarcomatoid mesothelioma in both cases. I was involved in the pathological diagnosis of these two cases, and my supervisor also agreed to diagnose these cases as sarcomatoid mesothelioma. At that time, we studied pathology from the textbook and from the teacher. The criteria of malignancy in in the sample. However, this idea was not correct. The two patients underwent extrapleural pneumonectomy to remove the whole tumor completely. Case 1 showed slight pleural thickening and also interlobar pleural thickening. Case 2 also showed slight thickening of pleura, and there was white nodules. I can see this here. There's a white nodule in the interlobar pleura. Case 1 lived more than 5 years after extrapleural pneumonectomy, and phase 2 died 2 years and 6 months after EPP. This slide shows microscopic findings of the EPP of both cases. Case 1 showed interlacing of artificial spindle cells, but the hyperchromasia of nuclei is not so prominent, and nuclear membrane was smooth. And furthermore, cellularity of the artificial cells is very minimum, and there are a lot of collagen fibers around the spindle cell. In case 2, this is the white nodules on macroscopic pictures, and there is a part of very cellular area and hypocellular area. The spindle cells, the number of spindle cells is very much, and the tumor invades into the lung. Final diagnosis of case 1 is fibrous pleuritis, and case 2 is desmoplastic mesothelioma. I was guilty of the overdiagnosis of case 1 and searched the best way to differentiate these two conditions. I have encountered this paper. This paper was published 2000, but I have read maybe in 2006 or 2007. The title of this paper is The Separation of Benign and Malignant Mesothelial Proliferation. This paper writes the diagnostic criteria for the desmoplastic mesothelioma very well. For the diagnosis of desmoplastic mesothelioma, invasion of adjacent tissue is very important. An adjacent area of definitive epithelioid or sarcomatoid mesothelioma or blunt necrosis are also useful diagnostic criteria. On the other hand, zonation is observed in fibrous pleuritis. The two pictures are from different patients, and the left picture shows desmoplastic mesothelioma. The tumor invades the chest wall and invades the pulmonary parenchyma. Right hand is a fibrous pleuritis. It shows zonation. For the pathological diagnosis, we must confirm mesothelial origin first and then differentiate benign from malignant mesothelial proliferation. I'm going to talk on separation of benign and malignant mesothelial proliferation first. Number 1 is species analysis of CDKN2A. CDKN2A is located on the short arm of chromosome 9. It is a cell cycle suppressor gene. It blocks the phosphorylation of the RB protein and arrests the cell cycle in G1. Downregulation or loss of CDKN2A expression result in enhanced or aberrant proliferation. Homozygous deletion of CDKN2A with tissue analysis in Mesothelioma is first published by Peter Ide in 2003. This slide shows the results of homozygous deletion of CDKN2A in sarcomatoid mesothelioma before 2000, where I found that the frequency of homozygous deletion of CDKN2A was high in sarcomatoid mesothelioma. We analyzed homozygous deletion of CDKN2A in mesothelioma cases and published the result in 2013. The title of this paper is Diagnostic Usefulness of P16 CDKN2A fish in distinguishing between sarcomatoid mesothelioma and fibrous pleuritis. This is the summary of the results of tissue analysis on tissue sections. homozygous deletion pattern was observed in fibrous fluids. A small number of cells in fibrous fluids shows homozygous deletion pattern, but it is due to artifactual cutting of nuclei. So we set the cutoff value at 14%. In epithelioid mesothelioma, 55% of the cases showed homozygous deletion of CDK and CK. And in sarcomatoid mesothelioma, all the cases showed homozygous deletion if we set the cutoff value as 14%. So we can differentiate sarcomatoid mesothelioma from fibrous fluids completely if we use the cutoff value of 40%. Next one is breast cancer 1 associated protein 1, BAP1. BAP1 is located on the short arm of chromosome 3. BAP1 can function as a tumor suppressor. It regulates several cellular functions such as chromatin remodeling, cellular differentiation, DNA damage response, etc. There are two papers. These two papers were breakthrough reports on genetic alteration of malignant mesothelioma. They were published in 2011. The above paper reported that there are families with high incidence of malignant mesothelioma due to germline mutation of BAP1. They also reported that 22% of sporadic mesothelioma also have mutation of BAP1. The paper below reported that somatic mutation of BAP1 was observed in 23% of mesotheliomas. Both of papers show that immunohistochemical analysis shows loss of BAP1. But at that time, nobody thought that immunohistochemical analysis of BAP1 can be used for the diagnosis of malignant mesothelioma. This slide shows poster presentation at USGAP 2013 in Baltimore. This is my presentation board, and next to my presentation, there was presentation of BAP1 immunohistochemistry in malignant mesothelioma. Their presentation shows that BAP1 protein is lost in more than 60% of malignant mesothelioma. After that, the paper showing that BAP1 immunohistochemistry is useful for differentiating malignant mesothelioma from reactive mesothelial proliferation. It was in 2015. And there is another paper showing that BAP1 immunohistochemistry is also useful in effusion cytology. And there are other papers showing that loss of BAP1 expression is observed in malignant mesothelioma, but rare in other malignancies. They are published in 2016. From these reports, BAP1 loss is highly specific not only in the differential diagnosis between mesothelioma and reactive mesothelial proliferation, but also with metastatic malignancy involving serous cavities. The third one is Methylthioadenosine phosphorylase MTAP. MTAP resides in the same gene cluster of 9p to 1 region and is co-deleted in the majority of CDK and 2A deleted cases. This paper shows that CDK and 2A and MTAP were co-deleted with tissue analysis of peritoneal mesothelioma. It was published in 2010. However, nobody thought that immunohistochemical analysis of MTAP can be used for the diagnosis of mesothelioma. These papers were published in 2017 and 2018. These papers showed that loss of MTAP protein is immunohistochemistry is related to homozygous deletion of CDKN2A with tissue analysis. Loss of MTAP protein with immunohistochemistry can be applied to both tissue sections and cell blocks of cell perfusion. MTAP is now thought to be a surrogate of homozygous deletion of CDKN2A with tissue. This is the summary of ancillary studies for distinguishing malignant mesothelioma from benign proliferation. BAP1 loss can be detected with immunohistochemistry. The frequency of BAP1 loss was higher in Epithelioid mesothelioma than sarcomatoid methylthiomas. Homozygous deletion of CDKN2A is detected with tissue. Frequency of homozygous deletion of CDKN2A is higher in sarcomatoid mesothelioma than epithelioid mesothelioma. MTAP loss can be detected with immunohistochemistry, and it can be a surrogate of homozygous deletion of CDKN2A with tissue. This case showed light pleural effusion and slight pleural thickening. Small nodules were observed on interlobe pleural. Lower picture shows artificial cells in pleural effusion. This slide shows immunohistochemistry of cell block of pleural effusion of this case. Mesothelial markers such as carotene, WT1, and D240 was positive. BAP1 protein was lost in epithelial cells, but inflammatory cells retained BAP1. MTAP protein was also lost in epithelial cells, and inflammatory cells retained MTAP protein. From these immunohistochemical results, this case can be diagnosed as mesothelioma with pleural effusion. This slide shows the pitfall of variation of loss of BAP1 protein. Positive internal control must be positive for the variation of negative BAP1 in the target cells. When the positive internal control is not staying well, the variation of BAP1 protein in the target cell is different. This patient had pleural effusion, and cell block was made from effusion. Mesothelial markers were positive, and calcium markers were negative. BAP1, this is BAP1, seemed to be lost in apoptosis, but staining of inflammatory cells is not so strong. It is very weak. MTAP is lost. This is a consultation case, and immunohistochemistry was re-examined in our laboratory. Re-examination shows that inflammatory cells retain BAP1 protein, and artificial cells also retain BAP1 protein. So BAP1 protein was not lost in this case. MTAP protein was lost again. This case shows that positive staining of internal control must be confirmed for the evaluation of BAP1 protein loss and MTAP protein loss. What test should be used to diagnose mesothelioma? I'm going to talk on confirmation of mesothelial origin. Immunohistochemistry is mandatory for the diagnosis of mesothelioma and epithelioid for the diagnosis of epithelioid mesothelioma. At least 2 mesothelial markers should be positive and 2 carcinoma markers should be negative. There are site-specific markers which shows the origin of the primary tumor. Pancytotherapy must be positive, and if it is negative, other tumors such as sarcoma should be considered. There are a lot of immunohistochemical markers which has been used for the pathological diagnosis of mesothelioma. However, some of them are not specific and sensitivity is low. So I only use the red markers in red first routinely for the diagnosis of mesothelioma at the first step. And if the immunohistochemical results of these markers are satisfactory, I do not stain anymore. Creatinine is one of mesothelial markers. However, it is not specific for mesothelial cells. Leydig cells of testes, Leydig cells of testes are also creatinine positive. This picture shows Leydig cell tumor. Creatinine is diffusely positive, but it is not mesothelioma. This is a needle biopsy of the pleural tumor. There are gland-like structures within fibrotic tissue. Creatinine was negative, but T240 was positive, and cytokeratin 5-6 were diffusely positive, but EP4 was also positive. This staining pattern suggests squamous cell carcinoma. And when you observe the biopsy sample carefully, you can see the keratinization here and here, and the pathological diagnosis of squamous cell carcinoma can be made. In this case, two mesothelial markers are positive, T240 and cytokeratin 5-6 were positive, but it is not mesothelioma. Carcinoma markers, mesothelial marker, two of mesothelial markers are positive, but it's not mesothelioma. In this case, carcinoma markers such as Claudin or P40 should have been performed. Claudin PEG1. PEG1 is a new mesothelium. It is heart of glass gene regulating the concentric growth of zebrafish heart. It regulates an endothelial cell signaling pathway and regulates proliferation of mesothelioma cells. It is highly sensitive and specific for malignant mesothelioma. We have published a paper on PEG1 on mesothelioma cell in inclusion. PEG1 expression was expressed on the surface of the cluster of the mesothelial cells. PEG1 was expressed in all of 41 mesothelioma cases. This is all of the cases have serosal effusion, and atypical cells are detected in the serosal effusion. And all of the mesothelium cells were positive for PEG1. But 77% of reactive mesothelial cells also positive. And if we use the BAP1, MTAP, and P16 fish, more than 90% of the cases were diagnosed as malignant with these markers. And this is double staining of PEG1 and BAP1. PEG1 is positive and BAP1 is lost in this cluster. So this is mesothelioma cells. These are mesothelioma cells. And here, this cells react with PEG1, but MTAP BAP1 was retained. So these cells are reactive mesothelial cells. Site-specific markers can help in determining tumor origin. TTF1 for lung adenocarcinoma is important. Colon cancer express CDH2 and ovarian cells cancer express ER and PAX8. This case shows diffuse pleural thickening. So clinician suspected mesothelioma. The autopsy was performed. These artificial cells were negative for all of the mesothelial markers, and TTF1 was positive. So we have diagnosed this case as pleomorphic carcinoma of the lung. Because the tumor encases the whole lung, macroscopic appearance is similar to mesothelioma. So we call this case as pseudomesothelioma carcinoma. Claudins are family of tight junction associated proteins. There are many claudins. Claudin 4 shows a higher sensitivity and specificity for the diagnosis of carcinoma than conventional carcinoma markers. It is first reported in 2006 and 2007. It is reported to be positive in most of carcinomas and negative in mesotheliomas. However, its usefulness for the diagnosis of mesothelioma has not been noticed until 2010. This paper was reported in 2010. Claudin 4 is useful in cytological diagnosis of cellular effusion. It shows that Claudin 4 was positive in most of carcinomas and negative in mesothelioma and in reactive mesothelial cells. This slide shows partial resection of the lung. The tumor shows solid growth with small glands. Caroteny was positive, so mesothelioma was suspected, and additional staining was performed. We used Claudin 4 and PEG1. Claudin 4 was diffusely positive, and the PEG1 showed the original mesothelial cell line. PEG1 was positive in original mesothelial cells on the surface of the lung. Pathological diagnosis of this tumor was carcinoma, not mesothelioma. BAP1 and MOX31 are thought to be carcinoma markers, but are they good carcinoma markers? This is a consultation case. 70-year-old man was suspected to have peritoneal mesothelioma, and autopsy was performed. Macroscopic findings were compatible with peritoneal mesothelioma, and the mesothelioma markers were positive. However, carcinoma markers such as BAP4 and MOX31 and CA125 were positive. This picture shows a positive staining of BAP4 and CA125. These results show that this tumor was mesothelioma, and we stained Claudin 4 and PEG1. Claudin 4 was negative and PEG1 was positive. These results show that this tumor was mesothelioma and not carcinoma, although BAP4, MOX31, and CA125 were positive. And thought to be carcinoma markers for the differential diagnosis of mesothelioma. However, positive staining of BAP4 and MOX31 in Epithelioid mesothelioma were reported in 1998. CA125 is also positive in peritoneal mesothelioma as well as ovarian and peritoneal carcinomas. This slide shows relative percentage of mesothelioma and lung adenocarcinoma expressing various immunohistochemical markers. This paper seems to be Turkish journal. BRCA-4 was positive in 20% of mesotheliomas, and MOX31 was positive in approximately 10% of mesotheliomas. This slide shows WHO classification of thoracic tumor published this year. There is a description that BRCA-4 or MOX31 are commonly used carcinoma markers. I consider the utility of BRCA-4 MOX or MOX31 for differential diagnosis of mesothelioma. When BRCA-4 or MOX31 are negative and mesothelioma markers are positive, it may be mesothelioma or reactive cells. However, even though BRCA-4 or MOX31 are positive, if mesothelioma markers are positive, the diagnosis becomes mesothelioma. So we don't have to stain BRCA-4 or MOX31. I do not think that BRCA-4 and MOX31 are good markers for the diagnosis of mesothelioma. Claudin-4 is better. When Claudin-4 is positive, it is not mesothelioma but carcinoma. When Claudin-4 is negative and the mesothelioma markers are positive, and the diagnosis becomes mesothelioma or reactive mesothelial cells. This slide shows immunohistochemical markers which should not be used for the diagnosis of mesothelioma. I have talked on BRCA-4, MOX31, and CA125 already. CK7 and CK20 are stained when the origin of the tumor is unclear. However, CK7 is positive and CK20 is negative in both mesothelioma and pulmonary carcinoma. And some of mesothelioma express CK20. Vimentin can be positive both in mesothelioma and pulmonary carcinoma. CD10 is a marker of for renal cell carcinoma, but it can be positive in mesothelioma. This slide shows immunohistochemical marker which should be used carefully for the diagnosis of mesothelioma. WT1 can be positive in ovarian carcinoma. CEA is negative in carcinoma of various organs and carcinoma tumor. PAX8 is positive in ovarian carcinoma, but is also positive in peritoneal mesothelioma. GATA3 is positive in breast cancer, Pleural carcinomas, but it can be positive in mesotheliomas. The transducer-like enhancer of SCLIP1, PLE1, is a marker of synovial sarcoma, but it can be positive in mesotheliomas. And endothelial markers can be positive in mesotheliomas. And next, I want to talk on subtyping of epithelioid mesotheliomas. They are divided with architectural patterns and divided with cytological features. The tubular papillary pattern is most often observed in epithelioid mesothelioma. This is trabecular pattern, and this is solid pattern. This is deciduoid pattern, and this is EPP case, extrapleural pneumonectomy of mesothelioma. This is epithelioid mesothelioma, which shows tubular papillary pattern, and this clear one is clear cell features. CD10 is a marker for renal cell carcinoma, but this case was also positive for CT10. And this patient has pleural effusion, and cytology of pleural effusion of this case also shows clear cell features. And this is BAT biopsy of pleural tumor. The tumor cells were small and the nuclear to cytoplasmic ratio was high. There are few cells with eosinophilic cytoplasm. Mesothelial markers are positive and carcinoma markers were negative. BAP1 was lost and MTAP was lost. So this is definitely mesothelioma, epithelioid mesothelioma, and with small cell features. This picture is small cell lung carcinoma obtained by BBLP. The microscopic picture of this case is similar to small cell carcinoma of sarcomatoid mesothelioma is also subdivided by those classifications. Desmoplastic, sarcomatoid with heterologous differentiation, transitional mesothelioma, and pleomorphic and lymphohistiocyte. And pleomorphic and lymphocyte mesothelioma can be epithelioid biphasic or sarcomatoid mesothelioma. So these two patterns are observed in epithelioid biphasic or sarcomatoid mesothelioma. This is batch biopsy of right pleural tumor. Hyperchromatic spindle cells proliferate and the cellularity is very high. CD56 was positive. This microscopic findings is very similar close to synovial. This is the case with synovial sarcoma. However, cytotherapy was diffusely positive, and D240 and WT1 was locally positive, and MTAP was lost. SS18 SSX fusion protein was positive, which is detected in synovial sarcoma. And the SS18 SSX fusion protein was negative in this case. This is a positive control, which is synovial sarcoma. So we diagnose this case as sarcomatoid mesothelioma, mimicking synovial sarcoma. This slide shows the immunohistochemistry of synovial sarcoma. CD99 and BCL2 were positive, but these were not specific for synovial sarcoma. And TLE1 was positive, but mesothelioma can express TLE1, so it is not diagnostic. SS18 SSX fusion protein was positive in this case, and we confirmed the break apart of SS18 with this analysis. So ICS18 SSX protein fusion protein is diagnostic for synovial sarcoma. This is a recently published report of minimalist panel for the diagnosis of mesothelioma. They reported that Claudin 4 and BAP1 are effective in the differential diagnosis of carcinoma and mesothelioma. I consider the utility of this minimalist panel of two markers. When Claudin 4 was positive, it is not mesothelioma. So this minimalist panel works very well. However, when Claudin 4 was negative, it may be mesothelioma or melanoma or reactive mesothelial cells. If BAP1 is lost, the probability of mesothelioma is very high. However, if BAP1 is positive, it may be mesothelioma or reactive mesothelial cells. So definitely diagnosis of mesothelioma cannot be made in place with negative Claudin 4 and positive BAP1. I think immunohistochemistry with only two antibodies for the diagnosis of mesothelioma is too simple. What tests should be used to diagnose mesothelioma? It depends on morphology of the specimen. If the differentiation is between early epithelioid mesothelioma and reactive mesothelioma cells, I use BAP1, Claudin 4, BAP1, and MTAP. If the differential diagnosis between advanced stage mesothelioma and carcinoma, we don't have to stain BAP1 and MTAP. I stain carcinomin W1B240 and Claudin 4 and TTF1 and P40 if it is tumor. If differentiation diagnosis is between early stage sarcomatoid mesothelioma and fibrous pleuritis, I will use stain cytokeratin and mesothelial markers, and I will confirm homozygous deletion on CDKN2A with FISH analysis. If the differential diagnosis between advanced sarcomatoid mesothelioma and sarcoma, I will stain cytokeratin and mesothelial markers. Differential diagnosis between sarcomatoid mesothelioma and sarcomatoid carcinoma of the lung is very difficult. There are two histological findings. This comes from two cases. Atypical cells proliferate in both cases. Left-hand slide is an autopsy case of sarcomatoid mesothelioma, and the right-hand slide is a lobectomy of lung carcinoma, and the pathological diagnosis is sarcomatoid carcinoma. When you see the macroscopic findings, it is easy to diagnose this is mesothelioma and this is carcinoma, but if you see the microscopic findings and intensely, it is difficult to differentiate sarcomatoid mesothelioma and sarcomatoid carcinoma. So this is a lesson from my experience. It is important for the pathologist to evaluate the biopsy as benign or malignant. It may be obvious in most of the cases, but there are some cases which is difficult. That is on small pleural biopsy. New and precious information is not written in the textbook, and your supervisor also may not know it. There may be pioneer in the world use internet to get the new information. In the old days, I went to the library and made a copy of the article in the journal and I could read it. But now I can download a PDF of the published articles, maybe from 2005. So now doctors can access the internet to read the medical journal published all over the world and get the updated information. This is all which I want to talk. Thank you for your attention.
Thank you.
Thank you very much.
Yes, Dr. Emine Dündar, please.
Yeah.
Yes, thank you very much, Dr. Hiroshima, for your good presentation and very good case pictures to show us. They are very beautiful. Thank you. We actually meet some problems in the differential diagnosis of the carcinoma and mesothelioma sometimes, especially when the MOC31 and I feel very stressed. And from your presentation, I took Claudin 4 for me. It's a very good case to solve this problem, I think. I will use, actually. Thank you.
Thank you very much.
Are there any questions to Dr. Hiroshima?
Question. much, Dr. Hiroshima. Can I ask a question?
Yes, please.
Yes. Which MTAP clone are you using the daily practice? And which company product are you recommend to buying the MTAP clone?
Company, what antibiotic cloning for?
Sorry?
What which antibiotic you
For
ask?
MTAP immunohistochemistry using MTAP.
For MTAP.
You are
Yes.
MTAP?
Yes, MTAP.
and-
Which clone are you using, and then which company are you recommend to us buying this one?
Companies from Taiwan, Abnova.
Abnova.
And don't, I used BA2, but it's not commercially available now. So that was another, we must buy another one. Please
So
read.
we asked the cell signaling technology company, and then they are saying these are only the research use only, and not the, for the diagnosis. They said that's why they don't sell. They don't want to sell to us MTAP primary anticoag.
The company is Abnova, ABNO.
Okay, I understood. Okay, thank you.
The company shows a list of drones, but
Okay.
my drone DS2 is not available now.
Okay.
So please use another one. I will write an email to the Methylthioadenosine about this matter, and please use of tell
Okay,
everybody
can I,
about the drones.
can I write my email address to you? Can I write my email address for the writing to me? Okay.
Yes.
Thank you very much. I'm Bilge Oğuz from Istanbul University.
I'm sorry,
Yes.
I cannot understand who I am talking with.
I am writing my email address. I'm working in Istanbul University, Cerrahpaşa. I'm writing my email address to send me the detail about.
So please send me your email address to me.
Yes.
Okay. Okay, I see.
Oh, I'll write to chat from the chat. Is it right? From chat, or I can send a private mail to you. Which one is it?
I'm not. I cannot answer the exact name of the clone now. So I can.
Okay.
I go to my office and check it.
Okay.
And
Thank you very much.
Write the email to you.
Thank you very much. Thank you.
You're welcome.
Are there any questions? More questions?
Yes, I see a question from Muzaffer. First of all, he thanks you for this great lecture. His question is, can BAP1 and MTAP immunohistochemistry be useful to predict response to therapy and prognosis?
Prognosis.
Yes,
There are
and
some papers on BAP1.
yes, BAP1
Yes,
and MTAP.
There are contradictory papers. Some papers said that BAP1, if BAP1 is positive, the prognosis is good. But some say BAP1, but some say BAP1 loss has good prognosis. But some say that it is not decided yet. But I think BAP1 loss is observed in epithelioid mesothelioma very often. In sarcomatoid mesothelioma, it is very rare. Usually, epithelioid mesothelioma has better prognosis than sarcomatoid mesothelioma. So if you combine epithelioid and sarcomatoid mesothelioma both in your analysis, BAP1 positive case may have poor prognosis because BAP1 loss is observed often in epithelioid mesothelioma. So I think the same thing is happening in MTAP. MTAP loss is related to homozygous deletion of CDKN2A, and the patient with a homozygous deletion of CDKN2A has poor prognosis than without homozygous deletion. So I think MTAP loss may have poor prognosis than retaining MTAP protein. But if you select only epithelioid mesothelioma or sarcomatoid mesothelioma, the story will be different. I think most of the sarcomatoid mesothelioma lose MTAP. That is the same as in CDKN homozygous deletion. So you can check only epithelioid mesothelioma. The patient epithelioid mesothelioma with MTAP loss, and you have to compare epithelioid mesothelioma without MTAP loss. But it is not. I don't know the good paper. This is my image.
Okay, thank you.
May I ask a question again?
Yes.
Are you giving the final diagnosis with cytologic examination?
Cytological examination?
Yes. Do you say malignant mesothelioma with cytologic examination?
Yes.
Without tissue.
Without tissue?
Without tissue, yes,
Yeah.
I can diagnose mesothelioma only. We cannot say it is epithelioid or biphasic. Some of mesothelioma diagnosis with cytology may be epithelioid mesothelioma, and some are biological diagnosis.
Yes.
So to know it is epithelioid or biphasic, you need to see the biopsy samples. So cytological diagnosis is only to diagnose it is mesothelioma. That may be epithelioid or biphasic.
Yes. Thank you very much.
You're welcome.
Muzaffer abi var mı? Ekleyeceğiniz bir şey.
Yok. Thank you very much for your clear lecture. I am sure that it will be very useful for our next research. Thank you, and I hope we can see you another in Turkey, another time in Turkey, face to face. Thank you very much.
Sorry.
Second Turkish, Japanese, medicine work.
Yes.
Scandinavia.
I hope.
There is one more question I see. I try to see again. Some of our friends ask, are you using grading in mesothelioma?
Grading.
Yeah.
Grading is proposed by Chicago University, Dr. Sane, and it may be good, but I don't have any data or my personal data on the grading of melanomas.
Thank you very much. Thank you. Are there more questions? I think no.
Doktor Harika yazıyor galiba önünde. Doktorunu yok peki. Pardon. Önünde klavyede yazıyor gibi gördüm ama evet.
Yes, I think we
can close.
Yes, we can close.
Excuse me. Another question.
Yes, We couldn't. Which do you use Claudin for? Which Claudin for? They ask to you.
You asking about clone of Claudin for?
Which how can I tell this item? Which do you use Claudin for clone? They ask.
Which clone?
Which clone?
We bought from one company. I'm sorry, I couldn't answer now. I have to go to my laboratory to check the clone of Claudin 4.
Okay.
So MTAP, clone of MTAP is one question, and clone of Claudin 4 is another question.
Okay, thank you. We will
I
wait
will write an email.
Okay, thank you very much. We will wait your answer.
I see Dr. Handan Zeren wants to ask maybe a question. Or
Hi.